Dear doctors, on World Hypertension Day, we have organized three online lectures to provide you with valuable insights and updates on hypertension management. Our first lecture will focus on isolated systolic hypertension in the elderly. This lecture will cover the prevalence and diagnosis of isolated systolic hypertension in elderly patients. Our expert speaker will also discuss the treatment options available, including lifestyle modifications and pharmacological interventions. Now, the second lecture will explore hypertension in children. Our speaker will discuss the prevalence of hypertension, risk factors, potential complications. We will also examine the diagnosis and management of hypertension in children, including non pharmacological and pharmacological interventions. Our third and final lecture will tackle the challenges in hypertension management. This lecture will cover the management of hypertension in patients with comorbidities, such as diabetes or chronic kidney disease. We will also discuss the challenges of patient adherence to treatment and explore ways to improve patient outcomes. Now, all three lectures are designed to be interactive and engaging, enabling you to ask questions and participate in the discussions with our expert speakers. We would also like to believe that these lectures will provide you with valuable insights and practical strategies to improve the management of hypertension in your practice. I urge you to participate actively in these lectures and make the most of this opportunity to learn from our experts and engage in meaningful discussions. Together, let us work towards raising awareness about hypertension and its management and strive towards better health outcomes for our patients. Thank you, and I look forward to your participation in these lectures. So, welcome to the day one of our program. We hope you got a chance to watch our first program by Dr. Shubhangi Kantikar, who spoke in length about the isolated systolic hypertension in children. Now, our next lecture this evening is by Dr. Munesh Tomar. Welcome, ma'am. Dr. Munesh Tomar is a national NBE coordinator for pediatric cardiology, and her areas of expertise include the management of congenital heart disease and arrhythmias. Dr. Tomar has performed numerous procedures for varied congenital heart defects, and she's also received many awards, including the Thakur Ulfat Rai Gold Medal for the Best MD Candidate by the Honorable Prime Minister of India, and also the Most Promising Doctor Pediatric Cardiology 2009 at Escorts Heart Health Institute and Research Center. She is currently the Director and Head of Department of Pediatric Cardiology and Congenital Heart Disease at Max Super Specialty Hospital in Saket, New Delhi. She's going to talk about hypertension in children. So let's begin.
Very good evening, everybody. Today we will talk about hypertension in childhood. It is a very important topic to be discussed. I'm Dr. Munesh Tomar, Director Pediatric Cardiology at Max Super Specialty Hospital, Saket, New Delhi. Starting with the interesting case, this is 8-year-old child, and he was having severe symptoms for 1 month, respiratory distress, swelling all over body, because of respiratory distress and cough, he was started on antitubercular treatment. As he was not getting better, chest X-ray was done. It was showing cardiomegaly, and he was referred for cardiology evaluation. He was in congestive cardiac failure. There was gross cardiomegaly, hepatomegaly, though pulses were well palpable. And if you look at the monitor, so look at his blood pressure. For 8-year-old child, the blood pressure of 170 by 123. Blood pressure too high for him. And obviously, everything was related to his severe hypertension leading to congestive cardiac failure, and on echocardiography, you see severe left ventricular dysfunction with moderate mitral regurgitation. He was stabilized by antihypertensive medication. Diagnosis was of chronic renal disease, and now he is currently on medication with normal ejection fraction. So this is the presentation of severe hypertension in a child when he is not diagnosed or treated on time. Why we are discussing about the hypertension in childhood? There is significant increase in interest in childhood hypertension since 2004. The recent update, which was 5 years ago in American Academy of Pediatrics, that around 3 to 3.5% of children have hypertension. We don't have exact India data, but various studies showed prevalence distribution around 0.46 to 11.7%. So a wide range of hypertension in childhood reported from the school-going children. Exact incidence or prevalence we don't know, but hypertension is a significant issue in pediatric age group also as in adults. Why it is important? Controlling and diagnosing hypertension in childhood, because childhood hypertension increases the risk of adulthood hypertension, and obviously adulthood hypertension leading to cardiovascular disease. Same thing, early starting of these hypertension, cardiovascular risk factors leads to accelerated vascular aging, and that further lead to cardiovascular accidents and cardiovascular issues in the older age. So the importance is to diagnose the hypertension in childhood, treat it adequately so that we can prevent its long-term morbidity related to hypertension. So this is a very important issue to be dealt with. In 2017, the definitions have been little bit modified. So now the blood pressure has been, the two categories they made, that 1 to 13 year and more than 13 year. More than 13 year, all the kids, they were in, or definitions are as for the adult hypertension. So there are four categories: normal blood pressure, which is less than 98th percentile, elevated blood pressure more than 98th percentile to less than 95th percentile. So in between that category is taken as the elevated blood pressure. And absolute number wise, if it is more than 120 by 80 to less than 95th percentile, whichever is lower, we have to take the lower numbers to catch these kids early. Then stage 1 hypertension is more than 95th percentile to less than 95th plus 12 mmHg, or absolute number wise 130 by 80 to 140 by 90 millimeter of mercury, again whichever is lower. Stage 2 hypertension, if it is more than 95th percentile plus 12 mmHg, or any blood pressure more than 90 millimeter of mercury, whichever is lower. So these are the numbers, definition are given for the hypertension. In the initial guidelines, before this 2017 guidelines, means all the kids, so-called normal children, the blood pressure was taken, and the definition of the percentile was defined by that. Now in 2017 guideline, the children with who are normal. Normal means weight for height is normal. So those kids were taken, and blood pressure, according to their blood pressure, these percentiles were defined. That's why we have a slightly lower number to catch these hypertension in these kids. For children more than 13 years of age, any blood pressure normal is less than 120 by 80, elevated 120 to 130 of systolic and diastolic of 80, and stage 1 hypertension 130 by 80 to 140 by 90, and stage 2 hypertension if it is more than 140 by 90 mmHg. So these are the new definition for the hypertension in kids and on the grown-up children also. For the neonates and infants, whatever was there according to second task force is being used to define blood pressure or the hypertension. And by this, these tables have been created. These are height, age, and male and female. So these tables have been created, and if we look carefully, so suppose for 1 year we have height percentile 5 to 95th percentile, we have height 5th percentile to 95th percentile, and according to that the blood pressure. So I have to take to go through this table to define these as. So to make easy for the OPD catching these kids early, the simplified table has been created, and we all should have this table in our OPD. 1 to 13 year of age group, systolic, diastolic, and mean for boy and girl has been put there. So for 1 year, 98 by 52 blood pressure. So this is the 90th percentile at fifth height percentile. So this is the minimum number we have, and above that it will be elevated blood pressure. So obviously, if it is above this range, I have to recheck, I have to call the child for follow-up, so that we should not miss hypertension in these kids. So this is a very simple table to put in OPD to catch these kids early for the blood pressure point of view. How to make diagnosis? The important thing, how to make diagnosis of hypertension, who can label them? So obviously the person should be a trained healthcare professional. It should be done in office setting. Auscultatory confirmed blood pressure more than 95 percentile at 3 different visits is labeled to label them hypertension. So we have many different parameters like school screening or at home screening, where we can have check blood pressure. If we get a higher number of BP in these kids, we should call them to the OPD, and there we should have a proper auscultatory confirmed blood pressure to label them hypertension, and obviously not to miss hypertension and to avoid over treatment of hypertension. So it is very important how we check blood pressure, when we check blood pressure, and according to that, this definition is given so that not to over treat or not to under treat. Plus, in pediatric age group, secondary hypertension is very common. That's why if we diagnose a child with hypertension, we'll get to know what is the underlying disease leading to this hypertension, so that we can treat the primary disease to prevent the long-term issues of the hypertension in these kids. When to check blood pressure, all kids more than 3 years of age annually should get their blood pressure checkup. This is annually as a routine practice. But at every healthcare encounter, if child is obese, he's taking medication which can increase blood pressure, if there is history of renal or diabetes, or history of arch obstruction, coarctation of aorta. So if high risk factor is there, we need to see them, check blood pressure at every health encounter. Otherwise, in a no associated medical issue, annually we should check like other health parameters, your weight, height, we should take blood pressure also. The confirmation should be by, as I told, by auscultatory method. If it is more than 95th percentile at 3 different visits, we should to label them hypertensive. And important to know it is adequate cuff size. If I take a small cuff, I will overestimate blood pressure. If I take large cuff for that child, I will underestimate the blood pressure. So correct cuff size is important. Who is checking blood pressure is important. How child is like in an agitated child, if I am checking blood pressure, it will obviously give wrong reading. So the technique of taking blood pressure is very important. It's a very, very important vital number which to give to a child. So correct checking is very important. Whenever doubt, like if there is family history of hypertension, or in these conditions like renal disease or diabetes, we should advise for the ambulatory blood pressure monitoring. That is a 24-hour BP monitoring. So a cuff is put across the child and a small monitor child carry, and we get everything in over the 24 hours in our computer. So to look for the variability in the blood pressure, like during when child is sleeping, there is some fall in blood pressure. When he's awake, there is increase in that. During activity, what are changes happening? So this diurnal variation is very important. If it is not there, then it means that is also not good. To differentiate between the white coat hypertension or it is true hypertension, this ambulatory blood pressure will be helpful. If it is mass hypertension, means child is having normal blood pressure during OPD and I have symptoms are not something suggestive of like intermittent headache or something, then obviously we should ask for the ambulatory blood pressure monitoring. So ambulatory blood pressure monitoring at present era is recommended whenever we are labeling a child or adult with hypertension. This is a very simple tool of investigation and is available. We have numbers according to child weight, height, male, female. So according to those, all data has been created and should be used, should make a routine practice to use hypertension, taking of the blood pressure in routine OPD care by a pediatrician or the treating physician. Etiology we all know that is primary hypertension or secondary hypertension. Secondary in pediatric age group, secondary hypertension is commoner than primary hypertension. And if I'm checking the blood pressure, diastolic is dominantly high. So that point towards the secondary hypertension. These are some subtle clues towards that we need to investigate more. When to think for the primary hypertension? So older kid with family history of hypertension, or he or she is overweight or obese, or plus important history and physical examination to be done to rule out any evidence of secondary hypertension. So if that is excluded, plus family history is there, plus or child is overweight or obese, we should think for the primary hypertension. But better to rule out the secondary causes by history examination and if needed by the laboratory investigations. So primary hypertension require different long-term treatment, while in the secondary hypertension, if we remove the culprit, will make him much better, we make the child much better to reduce the load of the hypertension on follow-up. The causes secondary, the commonest is the renal, followed by cardiac or the hormonal. Renal, a wide range. By studies wise, there's wide range contributing renal contribution as a cause of hypertension. So 34% to 76%. The renal could be parenchymal or structural. Renal artery disease is around 12% of cases. Then we may have coarctation of aorta arteritis or drugs or neurological and metabolic hypercalcemia, acute intermittent porphyria. Hypercalcemia present with polyuria, polydipsia, and hypertension. So in these conditions, we should check for the electrolytes in all patients with a hypertension. Then the endocrinal pheochromocytoma is a very important cause to be ruled out, and it usually have a episodic sort of hypertension. Sudden surge of the adrenaline leads to the surge in increasing high blood pressure, and child becomes sick. So that typical history they give. And important to know is when the pheochromocytoma is the culprit. With severe hypertension, you get severe tachycardia. So child with tachycardia with hypertension, we have to think for the pheochromocytoma as a cause of as a culprit for secondary hypertension. You may have Cushing syndrome, hyperparathyroidism, neuroblastoma, ovarian or adrenal tumor. So a long list of secondary causes are there, but obviously we need to, our approach is very important. History examination, and then head of the investigation to reach a final diagnosis in these patients. From drug point of view, over-the-counter drugs, there are three categories routinely. Many patients or take decongestant, caffeine, NSAIDs, or alternative therapies like the herbal or the nutrition supplements. So these are the drugs very easily available and very commonly taken by these by the public, and that could be cause of transient hypertension. Then the prescription point of view, stimulant for ADHD or hyperactivity disorder, hormonal contraception, steroid, tricyclic antidepressant. These drugs may cause hypertension, and history is again important to know that whether the patient is taking some drug which could be a contributing factor towards the hypertension. Amphetamine, cocaine, so drug abuse is also existing. So should be checked for these things to know what is the culprit for hypertension. The commonest thing is the over-the-counter drug. From the drug point of view to cause transient hypertension in these patients. The presentation, newborn and infant, neonate and infant, they usually present with very, very vague symptoms like failure to thrive, irritability, not taking feed, respiratory distress, and if it's very high, may present with seizures or electrolyte imbalance, may lead to convulsion. So vague, very vague symptoms in these kids are there as a hypertension. So hypertension need to be picked up. So child come with a usual complaint, and that's why it is important to check blood pressure in all patients if they are presenting repeatedly, or if there is any of the things which secondary things I have discussed may lead to the hypertension. Older kids, they usually silent because they become used to for their blood pressure. Intermittent headache could be the presenting complaint. Tiredness, nausea, vomiting with coarctation because lower limb perfusion is compromised. So leg pain could be there with exercise, with activity or cycling. They complain of leg pains, and then the coarctation of aorta is being picked up. With visual, when blood pressure is severely elevated, may lead to encephalopathy, that is called Press syndrome. There could be the polyuria, polydipsia, or cardiac failure, like the index case I have started with cardiac failure leading to the severe, because of severe hypertension leading to congestive cardiac failure. To reach a diagnosis, physical examination is important. So first target should be keep a possibility of secondary hypertension, and those differential diagnoses in mind. Head-to-toe examination is very important. So you need to check obviously heart rate, blood pressure, saturation, how the breathing is, plus pulses should be checked in, or at least once. Pulses should be checked in all limbs, including carotids. So, like in Takayasu, you may have multiple vessels involvement. Even both upper limb, lower limb could be involved. So, it is the carotid only which you get. Subclavian are involved in the Takayasu. Renals are involved. So multiple vessels are involved, medium size. Carotid if you feel for the carotid, bounding carotid will be there. So that should be picked up to know the hypertension. Otherwise, very easily will miss this thing. Faces, depending on the underlying disease, if it is Cushing syndrome, Cushingoid faces, Williams syndrome have typical faces, Turner syndrome have typical faces. Williams syndrome may present with hypercalcemia leading to hypertension. Turner syndrome may have coarctation of aorta, so that could be a cause of the hypertension. So phases should be defined as whatever finding we are seeing, we should note in our book. General skin examination is also important to rule out connective tissue disorder, eyes, vision, fundus, cataract. Detailed checkup is important, and all patients with hypertension should have ophthalmic evaluation. This is as a rule should have. Cardiac is important because cardiac could be the culprit, or cardiac could be affected because of hypertension. It is important to know cardiac condition in any patient with hypertension. Per abdomen, if it is intra-abdominal tumor, you may feel lump, you may feel bruise because of the involvement in Takayasu or renal artery stenosis. You may get that. CNS, neuromuscular skeletal, so connective tissue disorder, or so these things should be diagnosed only if you do a good head-to-toe examination in patients with hypertension. So for whatever vague symptom, the child is coming to your OPD, if he's not responding the way you are keeping your first diagnosis, then all vitals should be checked, including hypertension, and a systematic examination head-to-toe should be done so that we should not miss any treatable factor for the cause of hypertension in these patients. Laboratory approach, like we should have a stepwise in what to be done. All investigation, obviously not indicated in all patients. We have a smart approach to advise the investigation. Some investigation to be done in all patients, like urine examination. When child with hypertension, because renal is the commonest cause, so urine examination has to be done. And chronic hypertension may lead to the microscopic hematuria, so that is important. Microscopic hematuria means your hypertension leading to renal compromise. That will further lead to the hypertension. So this vicious cycle we need to break. You need to know renal, you need to know the blood pressure. So urine analysis is very important. Serum electrolytes, blood urea creatinine should be done. Lipid profile, fasting or non-fasting. Renal ultrasound is indicated in younger kids if they are more than 6, or their typical history, family history of the for essential hypertension, then it's okay. Otherwise, better to rule out renal. So ultrasound is very simple and easily available test and should be done in these kids. If child is obese, then HbA1c is important because we need to know they may be having subtle diabetes. So 3-month sugar average we can get by HbA1c level, liver enzyme, and fasting lipid profile. So in all patients we can have fasting, non-fasting, but if child is obese, we should ask for the fasting lipid panel. Other tests, fasting serum glucose, again, HbA1c will tell me whether I need fasting or postprandial. So accordingly we go. Thyroid is if there is history suggestive of towards thyroid thing, we should get that. Sleep study, if family give the child snores a lot, or he is having day sleepiness, in this condition we should ask for the sleep study. Obstructive sleep apnea is one cause for hypertension. It also leads to the pulmonary hypertension. So obstructive sleep apnea means intermittent. There is snoring. He is intermittently getting up during night, plus daytime sleepiness, excessive. So these are the things points towards the obstructive sleep apnea, and these patients' sleep study is important because that have a different treatment modality. Drug screen, if there is doubt, we should check for that. And complete blood count, because these are the chronic patients. We should know the chronic, the blood counts, hemoglobin level in these patients, and hormonal assessment if history to facing towards that. So it's better to have a planned investigations in these patients, some investigation needed in all patients, plus in selective, depending on my history and examination. Renal Doppler, because renal artery stenosis on 10 to 12% of cases, so we have the suspicion comes when high diastolic pressure, that is pointing towards a secondary cause. Low potassium or discrepancy in kidney size on ultrasound. So these are the indicators when we should ask for the renal Doppler. In very small patients like 1 to 2 years of age, they are they do not allow to do a proper renal Doppler. So making them sedated and getting a renal Doppler done is very important. If not, and you have the suspicion by these numbers, it's better to ask for the CT angiography to define. So then you get the detailed information about that. So asking for the higher investigation is should be thing, because otherwise we can miss the simple disease like renal artery stenosis in these patients. Echocardiography is important, as I told you, like chronic hypertension lead to load on the heart. Plus, heart could be a culprit for the hypertension, like coarctation of aorta or Takayasu arteritis. So one is effect of hypertension. So LV hypertrophy will be there. LV hypertrophy means LV diastolic dysfunction. And if LV diastolic dysfunction is there, that is increases cardiovascular risk independent of blood pressure and BMI. So this is so important. So if LV hypertrophy is there on echocardiography, this is means target organ damage, and we should be aggressive in treating hypertension in these. We should not go slow when there is left ventricular hypertrophy. And this LV hypertrophy need to be followed. Your blood pressure treatment for hypertension need to follow up, and at the same time we need to follow for the LV hypertrophy. And obviously if echo-wise we are getting something arch narrowing or abdominal aorta narrowing, we need to know the diagnosis and we need to treat the culprit. Then the management point. So when you evaluated these patients, you need to what to follow, how to follow, and when to start the treatment in these patients. So patient evaluation and management by BP level is important. When your blood pressure is normal in your patient, just annual blood pressure should be checked. We should not tell that this BP is normal. No further checkup. Checkup is needed because these are variable changes. Hypertension may appear later in life, especially for the primary hypertension. So the initial child may be normal. With increasing weight or decreasing physical activity with time, he may develop blood pressure. So follow-up is important, annual monitoring if he is normal. Plus lifestyle modification is very important. So lifestyle modification should be told to all patients at whatever stage of hypertension, their blood pressure they are. For the elevated blood pressure, initial management, it showed elevated blood pressure. You don't need treatment. But again, lifestyle counseling is important, weight control is important, and nutrition is important. Telling them what is healthy, what is unhealthy is important. Avoidance of junk food is important. So everything should be talking to the family, to the patient, involving the patient. The child, though he's 6 years or 5 years, better to involve him or her in conversation when you are talking to the family and telling the child directly what is good, how to monitor his weight, how to look for his diet is important, because he himself has to take care of these things. So initial measurements, if the blood pressure is elevated, counseling is needed. Then you need to call them at 6-monthly interval. If it is persisting, like even 6 months or 12 months, blood pressure is on that range, we need further evaluation. In diagnostic evaluation is needed, including ambulatory blood pressure monitoring. Plus, subspecialty referral should be done at this particular time to avoid that we are not missing anything secondary cause of high blood pressure in these patients. Then stage 1 hypertension, initial assessment again. Then call early at 1 to 2 weeks. If it is still there at 3 months, still there, we need to have a detailed workup. Lifestyle modification I have already done over 3 months. So 3-month lifestyle modification, despite that, if BP high is elevated in first stage, it is persisting, I need to start them on treatment. So counseling is important, simultaneous evaluation should be done. And if it is persisting, the stage 1 hypertension after 3 months of the lifestyle modification, we need to go for the treatment. Plus, again, subspecialty referral. Better to have opinion with your pediatric cardiologist or cardiologist, depending on the age of the patient, so that I'm not missing something. Then stage 2 hypertension. This is something is important. So initial first assessment, I have to, again, lifestyle modification. Upper lower blood pressure checking is important in all stages, whether it is elevated or stage 1 or stage 2 hypertension. And then early starting treatment in these patients is important. So simultaneous evaluation, starting the treatment, subspecialty referral is indicated Stage 1 hypertension after lifestyle modification if not done, and stage 2 hypertension directly we should go for everything. If child is symptomatic or BP is more than 30 mmHg above 95th percentile or above 120, 120, 180, 120, in any adolescent, we should go for emergency care, early treatment of hypertension in these patients. So this is the way we approach, this is the way things are advised to control, to evaluate hypertension. First is to diagnose hypertension, then evaluate, then went to lifestyle modification, then went to start treatment in these patients. Overall treatment goal is to reduce the target organ damage. So if heart, if cardiac, if LV hypertrophy is there, I have to be aggressive, I have to reverse that. So good control is very important. Ophthalmic changes, neuro changes, these are all target organ damage, and we need to prevent those to the effort should be to reverse those changes. So good control of blood pressure is very important in these patients. The goal is to keep it less than 98th percentile or less than 130, 80 in adolescent. When chronic renal disease is there, the target should be more, means less than 58th percentile is indicated because kidney is already damaged. So my blood pressure control is very important in patients with the chronic renal disease. And we have two options, non-pharmacological and pharmacological. Non-pharmacological means your lifestyle modification. This is very, very important. Like if child in stage 2 hypertension, in that condition, starting medication, lifestyle modification, if both goes together, then reducing the medication is very well possible if we advise for a child is having a good lifestyle modification. Okay, so first thing, both thing, and with simultaneously working on lifestyle modification diet, the number of medication will come down and child continue with the lifestyle modification. And that is obviously a lifelong therapy, something is needed. From non-pharmacological, we have diet, that is DASH diet, means high in fruit, vegetable, with low in fat and dairy, and high in whole grain, fish, nuts, red meat. So this is the way our 50% of the thali should be occupied by fruits and vegetable, and rest 50% with all the roti, rice, and dal. So this is the way the thali distribution should be in these patients. Physical activity, 3 to 5 days. I tell them to keep 5 days a week, 30 to 60 minutes, moderate to vigorous. Again, when blood pressure is very high, like it's in stage 2 hypertension, I can't ask directly him for the vigorous activity, but starting activity is important. So mild to moderate and improvement in the blood pressure, with control in the blood pressure, they go for the vigorous activity. So gradually they need to increase their physical activity, not immediately targeting vigorous activity. So gradual is very important. Plus good control of hypertension, other things like your yoga, meditation, spiritual activity, music, whatever is helping, whatever thing is making the child quiet, calm, should be advised, should be done. Whatever interest the child have, whether he has in music or in drawing or in some special sports. So that interest should be kept in mind. To reduce the stress, that interest should continue along with control of the, when needed, pharmacological medication should be. So when to start the pharmacological medication? Indication, like as I told, stage 1, if there is failed lifestyle modification. So first 3 months, we try for lifestyle modification when child is stage 1. If still BP is persisting, we add the medication plus continued lifestyle modification. Regular follow-up is needed, and then you slowly withdraw the medication in some time, or sometime may not, depending on the response. If hypertension is stage 2 and we do not have a clearly modifiable factor, obviously we need to start on the medication. Plus, again, lifestyle modification to be continued. If we have modifiable factor, we need to treat that, like diabetes, renal factors, or the cardiac factor, or the anything like that, or the hormonal. So those things, or the drugs. So those should be removed. Pharmacology treatment for the hypertension plus lifestyle modification. If patient symptomatic, then we should not delay it. We have to admit the patient and treat. If hypertension is secondary, so on those conditions, obviously, modification will be there. Plus, you need most of the time pharmacological treatment in this. If there is evidence of target organ damage, So if there is left ventricular hypertrophy or systolic diastolic ventricle dysfunction or encephalopathy or stroke, TIA, chronic renal disease, rare retinopathy. So these are the absolute indications to start pharmacological treatment. And they require, so symptomatic or an organ damage is there, you need to hospitalize the patient, you evaluate, you simultaneously start the treatment. We need to be aggressive starting treatment in these patients. The drug of choice, different combinations are there. So one is physician choice, second is what the underlying cause of hypertension. So ACE inhibitor or the ARBs first as we start, then the calcium channel blocker or with or without thiazide diuretics. If these are not working, you may need to start on the central acting drugs like prazosin, clonidine, these things we need to start. Beta blockers or alpha beta blocker like labetalol if your pheochromocytoma, you are thinking as a factor, plus obviously that condition you need to send the patient for surgery. But the medicine you need, these are the common ACE inhibitor, ARBs, calcium channel blocker, thiazide. So these are the general group where we start on these kits. Keeping the differential diagnosis in mind, you may need to modify it. The second drug should be added, like single drug in adequate dose, it is not responding or response is not adequate, or you are developing, the patient is developing side effects, then we need to go addition of the second drug. If patient is renal or diabetic, ACE inhibitor or ARBs are better choice. If child is in hypertensive crisis, obviously emergency ICU admission, you need IV medication, and target should be 25% reduction in hypertension in 8 hours. So this is the way we go. So common drugs are there for the OPD practice. A regular follow-up is important to optimize the medication, to look for the effect of the medication and how blood pressure is controlled, how lifestyle modification. So each and every visit, we need to enforce for the lifestyle modification. We need to emphasize on for the good compliance of the medication. We need to check those things. Plus, obviously, you need to remove the culprit. This is important thing. So treating by drug management won't work if I am having coarctation of aorta. So this CT angiography is showing a very tortuous critical coarctation of aorta. So hardly any flow is being seen. And this is the stenting in same patients, a good bolus across with the stent in situ. So this is something correctable. The important point is coarctation of aorta. The later we intervene, the higher chances the child may have residual hypertension, child or adult may have residual hypertension on follow-up because of setting of the sympathetic receptors. So it is important to treat them early. So treat them early. Most of the time you get free of the hypertension, of the blood pressure, but older age, you may require a longer blood pressure medication to continue. But the pressure, the mechanical factor leading to hypertension is relieved. So they become much better. Blood pressure is better control. You came down from 3 medication to 1 medication. But obviously, if you are treating a patient 40 years of age for coarctation of aorta, like in this patient, you may not always, but chances. That's why we need a follow-up for all patients with hypertension. This is a 16-year-old girl with CHF, referred for LV dysfunction. And if you look, this is echo. So this is the abdominal area, which is severely narrow. This red flow is seeing. And this is angiography showing tight narrowing of the descending thoracic aorta, and which is being ballooned. After balloon dilatation, you can see a very good flow across the. So identifying the culprit plus treating is the answer whenever there is a mechanical is the. This is another adolescent girl with severe hypertension, and there is severe renal artery stenosis, which was ballooned, and then stenting was done, leading to very good flow across that. If it is tumor, then obviously you need to remove, like pheochromocytoma. You need to, sometimes the position is, the location of the tumor is so remote, or it's not in a usual position, then obviously you may need further scanning to find the tumor, and accordingly you need to send for the surgery. Medicine are there, but obviously surgery is the answer in these patients. So take home message is pediatric hypertension is not uncommon. It is there. 5% is a big number to have hypertension, looking at the number of children we have. So elevated blood pressure in childhood increases risk of adult hypertension, and adult CVD likely has its origin in childhood. So there are few diseases in adult. so have their origin in childhood, whether this is genetic or it is so-called primary or familial. So we need to catch these things early and treat them early. Measuring blood pressure annually is indicated in 3-year-old onward in all kids. But if there are other additional factors, we need to check early. Even in newborn, you require BP monitoring if they have preterm birth or prolonged NICU stay, they require umbilical artery catheterization. These are things you require BP monitoring even in newborn and infants also. So there are different indication meant to, but all in general, annually 3 year you have to check. Below that, if it is indicated, frequencies again depend on what underlying disease, secondary factor you are the child is carrying. Confirmation should be by auscultatory method. Correct technique, correct cuff size is important to get the correct blood pressure. And ambulatory blood pressure, we all should be comfortable with ambulatory BP monitoring and should be encouraged to get it done because that will give you a better idea about how blood pressure is controlled, whether it is hypertensive or not, should not be over-treated or should not be under-treated. Blood pressure classification is there, 2017 guideline, it is modified and should be used. That simple table should be in OPD to know when to call them early for recheck of the blood pressure. Treatment is important. So pharmacological is very important, should be in all patients. And when needed, we should go for the pharmacological medication. And you need to upgrade or reduce the medicine depending on the response. So a follow-up is very important. Counseling the family is important. Blood pressure is not something benign. We need to be all as a physician should take blood pressure as a serious issue, and knowing that blood pressure also exists in pediatric age group is very important to catch them early, to treat them timely, and obviously to correct them if we have a correctable factor in these patients. Thank you. So these 6 different cuff size are available, starting from newborn, infant, child, adult, and the large adult or obese patients at thigh, for the thigh. So these cuff size should be there in your OPD, at least newborn, infant, child, and adult. We need to have in our OPD so that taking correct blood pressure is important. Teaching the sister is important how to take blood pressure. So this should be make a habit for all of us, for all the pediatrician friends and all the physicians. Thank you.
Thank you so much, Dr. Tomar, for this wonderful lecture. I have a lot of questions for you. So, ma'am, my first question is primary hypertension in children has been attributed to several factors, including obesity, a diet, gender, and academic stress. What strategies can children adopt to manage this condition, and how can parents play a role in preventing this?
Okay, this is very important point. Actually, very good question is being asked. These are the all factors for the primary hypertension as discussed and as is being mentioned. Here comes the role of the family. Okay, so for the parents, so counseling, explaining by the involving the doctor in that these are the risk factors which may lead to hypertension. So this is important. The involving one is academic activity, because a lot of stress of the academic activity is there nowadays. Competition is tough. Keeping some non-academic interest or habit or hobby is very important to sort of neutralize the stress effect of that stress on our mind or body. So the child, if whatever interest he has, we need to develop, whether it is drawing or music or some sports activity. So keeping an hour or break plus developing some non-academic interest is very important to cope them. So and everybody should do. Encouragement about the yoga or meditation is very important, and that really help in controlling these stress, plus making them better, plus controlling the blood pressure. There are studies of effect of yoga on blood pressure, effect of yoga on heart rate. So we have the study, we have scientific evidence that these things help in controlling blood pressure, reducing the stress, and we as a society we need to encourage role of yoga and meditation that help a lot, improving the academic performance, reducing blood pressure, And we have the documented evidence for that and should be encouraged.
Thank you, ma'am. What are the potential consequences of leaving hypertension untreated in children, if I may say?
So, any disease, if we don't diagnose on time, if we don't treat on time, or then obviously have a, it's like a malignant hypertension, so-called. So you can, that word itself says how bad it is if you don't treat. The index case which I showed, because the blood pressure was not diagnosed, so obviously not treated, and child went into cardiac failure. So child may have cardiac failure, child may have intracranial bleed, child may have loss of vision, child may have renal failure because of hypertension. So it is a serious disease and bad disease. If we don't treat, it is a life-threatening condition. It may create life-threatening condition. So there is no question of not to treat. We need to treat. We need to control blood pressure. The child come to us, it is very late to diagnose hypertension. So, so I have to ask to look for the target organ damage. And most of the time, of changes in eyes are there, changes in kidney are there, heart is already hypertrophied. Okay, so these are the bad things which are happening because hypertension is being missed in kids.
Thank you so much, ma'am. My next question is, what actions can the government take to address this matter? Do you believe that implementing a color-coded system for pre-packaged food, let's say similar to the one used in UK, would assist parents in making informed purchasing decisions?
Yes, I think we need to think one is parents' responsibility, physicians' responsibility, society responsibility, and government responsibility. So because this disease is in the society. So naturally, it's the involvement of everybody is important. So the task should be done like we do go to school, check blood pressure in all school going children. So this is a very small step. It should be from the government policy, all kids, the blood pressure should be checked. Okay. And the high risk thing, the thing which can cause hypertension, like your pre-packed food, should, if we can label them, it would be important. And actually, the junk food, the packed food which we are taking all UK, it is different most of the time. But it is better to have our Indian food practice. We should have that coding according to our Indian food practice. And in general, the media, the newspapers, so by food, we should have create more activities to make people or the society have more aware about this serious issue. If a practice should be made, actually, so-called compulsory. If child is seeing in OPD, so some numbers should be given, like weight is this, height is this, okay, heart rate is this, oxygen level is, blood pressure. So these 5 numbers are very important. I think every physician, every pediatrician should make a habit of giving these numbers to the child and telling the parents that this is within normal limit or this is not within normal limit. Okay, so this habit we all as a physician should develop. These 5 numbers to be given to for any OPD visit.
Thank you, ma'am. Moving on to my next question. So, are there any complications associated with the treatment of hypertension in children?
Complication associated with treatment of hypertension. So this question, every drug has its side effect. Okay, none of, even paracetamol is not without side effects, but there are indication to use that. So whatever drug I'm using, suppose I'm using ACE inhibitor, which I was talking. ACE inhibitor have some electrolyte effect in body, may have kidney effects. So when I use, I need to have some basic blood tests done before starting that medication, and on follow-up we need to repeat blood test. Okay, so medicine, whatever medication we advise to the child or to the patient, it is better to tell about the side effect of that medicine also. In general, drug treatment will not cause complication. The treatment is to prevent complication of hypertension on long term. Okay, so the purpose is preventing the complication of hypertension. But whatever drug I'm using, I should know the side effect of that drug. Plus, I should tell the family that if there's what follow-up needed when the child is on that particular drug, to avoid the complication of the medication. So actually understanding the medicine by the physician who is prescribing, If I understand my medicine, what I am giving to my patient, I will explain him in a better way. This could be the side effect, so that we can monitor those things on follow up.
So, ma'am, how does hypertension in children differ from, let's say, hypertension in adults?
Like in adults, the hypertension main cause is primary, essential hypertension. While in pediatric, main cause is secondary hypertension. Hypertension is numbers are same, like I discussed, the definition wise. In pediatric, we go by percentile. In adult, we go by the absolute numbers. So if I label a child or an adult with hypertension, stage 2 hypertension, it is going to have equal bad effect in both. But in pediatric, because mainly it is secondary hypertension, so we can, if we treat the secondary cause on time, we remove the culprit on time, the outcome is much better than adult. Okay, but if we don't treat, this will go into the hypertension in adult age, having more of cardiovascular effects, early aging of the vasculature, coronary artery disease. So these are the blood pressure starting in pediatric age group have a longer persistence. If having longer persistence, obviously we'll have a more complication in adult age. So like in childhood, because it is more of secondary to other causes, if I remove that, my outcome will be better in this in pediatric age group. Hypertension is hypertension. It is equally bad for both.
Thank you, ma'am. One last question. So, what can be done to raise awareness of hypertension in children, and why is it so important to do?
Like we have discussed in previous question answers, these things, it is very important to raise awareness about the hypertension in childhood to the public, to the society, at the government level, at every level. We need to address this issue, because hypertension 3.5% as per the American Academy is there. In India, we don't know exact number, 0.5 to 11%. This is the number in school children in various states. So if 11% of kids, 10% of kids are having hypertension, you can see the load of kids with hypertension. So it is very important to know the awareness so that we can treat this on time. We can know the secondary, whatever the culprit causing hypertension. And very important, most common in today's era, obesity is increasing. Lifestyle is more of passive. So because of more use of the social media, those things. So child is spending more time on table than in physical activity. If we increase the awareness about hypertension, will obviously motivate them to going towards the field activity, towards the physical activity that have many benefits. Not only hypertension, it's overall healthy lifestyle we are going to give to these kids. So awareness is important because burden is huge. Burden, we need to work to reduce the burden, and whatever burden is there, we need to treat them on time so that we can prevent the long-term complication. So awareness is the answer to know the disease and to treat the disease. I think there should be no compromise about knowing this hypertension.
Thank you so much, Dr. Tomar, for all these answers and such an insightful lecture. Now, dear audience and our speakers for today, as we come to the end of day one of our series of online lectures on World Hypertension Day, I would like to extend my heartfelt thanks to all of our esteemed speakers and participants. Your valuable insights, knowledge, and expertise have made these lectures a resounding success. I'm also confident that the information and strategies you have shared with us to improve the management of hypertension in our practice and ultimately lead to better health outcomes for our patients. So, to our speakers, I would like to express my gratitude, Dr. Tomar and Dr. Shubhangi, for your time and effort in preparing and delivering these lectures. Your dedication and commitment to advancing the understanding and the treatment of hypertension are truly admirable, and your contributions have made it invaluable. To our dear audience, I would like to thank you for your participation and engagement. Your thoughtful questions and insightful comments have enriched our discussion and added to the depth of our knowledge. So stay tuned to the last lecture planned on 20th of May, 7 p.m. onwards, on how to tackle challenges in hypertension management. Let us continue to work together towards improving the health outcomes in our patients and raising awareness about hypertension and its management. Until we meet again, please take care and have a great evening ahead. Thank you so much.